In the right hands, spinal anesthesia, a neuraxial anesthesia technique, can be used to effectively provide anesthetic for lower abdominal and lower extremity surgery. In this film, relevant anatomic and physiological considerations will be discussed, as well as how to prepare equipment, medication, as well as a patient for the procedure. In broad terms, spinal anesthesia entails the introduction of local anesthetic into the cerebrospinal fluid. Anatomical landmarks seen being marked on the skin now are used to guide the advancement of the spinal needle into the subarachnoid space at the level of the lumbar spine. With the aid of an inlay, some anatomical structures will now be identified. The spinal column and its relation to the bony pelvis is now shown. Take note of spinous processes of the lumbar vertebra. The manner in which the patient is seated has a bearing on the orientation of these structures, which in turn has a bearing on the success of the needle being advanced from the skin into the subarachnoid space. In flexion, the space between the spinous processes is maximized, while in extension it is minimized. For this reason, it is important that the patient be positioned optimally, lying down or seated in lumbar flexion. In this position, a schematic will be used to demonstrate the relationship between the subcutaneous tissues traversed by the spinal needle. Take note of the spinous processes of the vertebra, the supraspinous ligament, the interspinous ligament with the interspinous space, the ligamentum flavum, the dura mater and closely adherent arachnoid matter, the subarachnoid space containing CSF and into which the local anesthetic is injected, the spinal cord, and finally the posterior longitudinal ligament. For neuraxial anesthesia to be performed effectively, the relationship between palpable and not palpable structures, as well as visible and not visible structures, needs to be understood. Neuraxial anesthesia may result in the complications of high or total spinal anesthesia. The action of the injected local anesthetic on sensory, motor, and sympathetic nerves may result in bradycardia, hypertension, and rapidly ascending paralysis. Depending on the level of paralysis and affected nerves, difficulty breathing or complete respiratory depression may occur. In some instances, the level of the spinal block may even cause airway compromise and unconsciousness. Therefore, before administering a spinal anesthetic, resuscitation equipment such as a laryngoscope and resuscitation medication such as atropine should always be prepared. Failure to establish an adequate spinal block may require conversion to a general anesthetic. For this reason, medication and equipment required for a general anesthetic should be prepared beforehand. Vasoconstrictors such as ephedrine or phenylephrine are required to treat hypotension that occurs as a result of sympathetic blockade. There is significant overlap between medications used for resuscitation and those used for induction of anesthesia. For more detailed elaboration of this, refer to the course Introduction to Anesthesia, Induction. Monitoring is a key component in the provision of anesthetic care. In addition to ECG electrodes, an oxygen saturation probe and blood pressure cuff are now placed on the patient. The minimum required monitoring during a spinal anesthetic is blood pressure, ECG, and oxygen saturation. Because of potential respiratory complications, some anaesthetists monitor end-tidal CO2 routinely. In the first 5 to 15 minutes of a spinal block, monitoring is essential. In this period, each of the previously mentioned parameters should be checked every 5 minutes to ensure the patient has not developed a high or total spinal anesthetic. Because of the risk of hypertension, it is essential that good intravenous access be established before administering spinal anesthesia. As previously mentioned, vasoconstrictors may be used to treat hypertension. This is, however, done in conjunction with fluid boluses. A fluid bag should be attached before commencing with the spinal anesthetic. Spinal anesthesia should be administered aseptically, and in some centres, the required implements, including the spinal needle, are pre-packaged in a sterile pack like this one. Given differences between hospitals, attention will not be given to how the pack is set up, but rather to what should be available when administering spinal anesthesia. As previously mentioned, this is an aseptic procedure. Local protocol for hand hygiene and aseptic technique should be followed. It is important to note that the intrathecal anesthetic now highlighted is contained within a glass ampule. To avoid injecting glass into the subarachnoid space, a draw-up needle is used. It has a filter that prevents the aspiration of glass particles into the syringe. Take note that the procedure has a bearing on the type of local anesthetic used. The onset of action, the duration of action, and the boricity of the local anesthetic will now be discussed briefly. There are a number of different types with different characteristics. A commonly used preparation is bupivacaine 0.5% in glucose 8%. Bupivacaine is a local anesthetic with a slow onset of action and a long duration of action. In combination with glucose, it is hyperbaric. Because the solution is more dense than cerebrospinal fluid or CSF, changing the patient's position influences its distribution and therefore its site of action. For example, if the patient is kept seated for a period of time following the injection, the long-acting anesthetic sinks, predominantly affecting the nerves innervating the perineum and the buttocks. This so-called saddle block anesthesia is ideal for perineal surgery. Returning to the sterile pack, take note of the spinal needle introducer, used to support the passage of a spinal needle through the skin and soft tissue. Pencil point spinal needles, which have a blunt tip, always require the use of an introducer. The spinal needle is available in different types and sizes. Selection of the type and size should be guided by the patient's profile. Large needles, for example, are known to be more likely to cause the complication of post-dural puncture headache in young pregnant patients, and their use in this group is avoided. With implements for intrathecal injection prepared, attention is now turned to the local anesthetic used to infiltrate the skin. The previously decanted lignocaine is now drawn up. This quick onset, short-acting local anesthetic is not routinely used intrathecally. Because of differences in duration of action, dosing, and potential toxicity, care should be taken to differentiate between the intrathecal and intradermal local anesthetic. Here, for example, lignocaine is drawn up in a 10 milliliter syringe and is capped with the needle that will be used to infiltrate the skin. Other contents of the spinal pack will briefly be noted. These are gauze swabs and a sponge applicator, both of which can be used to clean the skin prior to the procedure. Following cleaning of the skin, a sterile drape is used to cover unsterile skin caudal to the injection site. In anxious patients, midazolam may be of use in aiding positioning. Also present on this medication tray are the vasoconstrictors, ephedrine and phenylephrine, used to treat hypertension. Also present is atropine, used to treat bradycardia. With general preparation complete, attention can now be turned to patient positioning. Administering a spinal anesthetic very much relies on patient positioning. Positioning the patient in lumbar flexion, either lying down or sitting up, satisfies these conditions. In this film, spinal anesthesia is demonstrated with the patient seated. A schematic will now be used to demonstrate what should be done to optimally position the patient. Flexing the lumbar spine increases the vertical distance between the lumbar spinous processes. This larger interspinous space means a needle has a better chance of passing through the skin and into the subarachnoid space without encountering bone. The following measures may be used to help the patient maintain their position. Hugging a pillow helps to accentuate the lumbar flexion. Positioning the back of the knees as close as possible to the surgical table positions the patient's back closer to the anaesthetist. Placing the feet on a flat surface below the level of the table flexes the knees, which in turn aids lumbar spine flexion. And finally, an assistant to reassure the patient during the procedure. This assistant should not attempt to forcibly maneuver the patient into the required position. Because the procedure is performed at the patient's back, they are unaware of the movements of the anaesthetist. The assistant should therefore preempt and communicate the anaesthetist's movements to the patient. Complications can easily occur if the patient is startled and moves suddenly. With optimal positioning obtained, the injection site is now prepared. Site preparation begins with identifying the correct level for injection of the spinal anesthetic. The spinal cord terminates at the conus medullaris at the level of the L1-L2 interspace. Inserting a needle at this level or higher carries a risk of causing spinal cord injury and should not be done. The L2-L3 interspinous space, the L3-L4 interspinous space, and the L4-L5 interspinous space are considered safe for the administration of spinal anesthesia. Identification of these spaces using anatomical landmarks will now be demonstrated with the aid of an inlay. Here the pelvis and the lumbar vertebra are seen from posterior view. The intercrystal line is an imaginary line between the highest points of the iliac crests. It approximates the level of the L4 vertebral body and is used to identify the other vertebra. The iliac crests are palpated. The anaesthetist marks the level of both on either side and palpates the spinous process of L4 in the midline. The spinous process of L4 is now marked, as well as the spinous process of L5. The interspinous space between L4 and L5 has now been identified. Cleaning of the skin begins over the intended injection site and then works outwards away from it. The solution used typically contains chlorhexidine. While the anaesthetist puts on the sterile gloves, it is allowed to dry. This is because chlorhexidine is neurotoxic and should not be allowed to enter the subarachnoid space. The sterile drape is now positioned to cover the skin caudal to the injection site. If required, the anaesthetist may once again palpate the level of the iliac crests in order to confirm the L4-L5 space. With this done, the anaesthetist turns to the sterile tray or spinal pack and draws up the medication. Firstly, lignocaine in a 10 ml syringe and then bupivacaine. As always, it is important to check the contents and concentration of the ampule before administering any medication to a patient. The anaesthetist will now do so with the anaesthetic nurse, who in this film is off-screen. The confirmatory check is made visually and verbally. For this case, the anaesthetist uses an additive in conjunction with the bupivacaine. Assisted by the anaesthetic nurse, fentanyl, an opiate, is added to the local anaesthetic. Additives potentiate and/or prolong the action of intrathecal local anaesthetics. They have their own side effect profile, and care should be taken when selecting the type of additive as well as the dose. Advancement of the spinal needle will be demonstrated using two camera angles. The anaesthetist again palpates the desired interspinous space. Local anaesthetic lignocaine 1% is infiltrated into the skin and the underlying subcutaneous tissue. The needle is inserted into the skin and the subcutaneous tissue in its entirety. And infiltration is again performed as the needle is withdrawn. Bleeding from the skin is common and can be dealt with using a sterile gauze swab as now shown. The spinal needle introducer is now inserted into the skin and underlying subcutaneous tissue. Before insertion of a spinal needle is demonstrated, it is important to note that the anaesthetist is left-handed. To insert the spinal needle, the non-dominant hand is positioned against the patient's back as follows. The thumb and index finger are used to grasp the hub of the needle introducer. The backs of the index and middle finger are braced against the patient's back to provide stability, while the dominant hand is used to pick up the needle and advance it, as can now be seen. Take note of the angle at which the needle is advanced. At 10 to 15 degrees, it approximates the direction of the spinous processes, improving the procedure's chance of success. With regard to angulation and the needle hitting bone, the following rule of thumb applies. If bone is encountered at a shallow depth, the spinous process of the vertebra above is the likely culprit. Leave the introducer in place, withdraw the spinal needle completely, reinsert and redirect with reduced angulation. Conversely, if bone is hit at a deeper point, the spinous process below the space may be the problem. Leave the introducer in place, remove the spinal needle completely, reinsert and redirect with increased angulation. If changes in angle do not produce a change in the depth at which bone is encountered, consider the lamina as the source of the problem, meaning the introducer and needle are not in midline. Both should be removed and reinserted appropriately. If the angle is correct, the needle advances through the tissue layers and changes in resistance are felt. The needle is advanced slowly and surely until the distinctive pop of dural puncture is felt. To confirm this, the needle stylet is removed and the flow of CSF is watched for. As the CSF drains, take note of its clear quality. If there is blood staining, CSF should be allowed to drain until the blood clears. If the blood fails to clear, it's likely the needle is positioned within a blood vessel. Intravascular injection of local anesthetic carries a risk of systemic toxicity. The needle and introducer should be removed and the procedure re-attempted at a different level. Before injecting local anesthetic, the non-dominant hand stabilizes both the needle and the introducer. This prevents potential movement of the spinal needle out of the subarachnoid space. Once attached, the plunger is pulled back and a small amount of CSF is aspirated, confirming the needle is still in the subarachnoid space. The plunger is then pushed in slowly and steadily. Injecting quickly may result in a higher than intended spinal block. The introducer, spinal needle and syringe are removed as a single unit once injection is completed. A sterile dressing is applied to the injection site. How quickly the patient is moved into the desired position for surgery depends on the boricity of the local anesthetic and the desired site of action. In this case, bupivacaine with glucose was used, and the patient is kept seated for a period of time to allow the distribution of the local anesthetic to lower spinal levels. The assistant must maintain their position supporting the patient as the spinal anesthetic begins to take effect. These effects should now be monitored. Monitoring of blood pressure, pulse oximetry and ECG is mandatory throughout the spinal anesthetic. If non-invasive blood pressure is being used, the cuff should be on a 2.5 to 5 minute cycle in the first half hour of the spinal anesthetic. With the local anesthetic now distributed, the patient is assisted with lying down. Again, take note that lower limb paralysis places the patient at an increased risk of falling. With the patient positioned supine, the level of the spinal block is now tested. This relies on the use of dermatomes to determine which spinal nerve root has been blocked. Dermatomes are areas of skin that receive sensory innervation from a specific nerve root. The T10 spinal nerve root innervates the skin at the level of the umbilicus. Loss of sensation in this dermatome therefore indicates that the anesthetic has reached the level of T10. Loss of sensation at the level of the nipples indicates that the anesthetic has reached the level of T4. Knowledge of skin landmarks and dermatomes, along with a cold stimulus such as ethyl chloride spray, helps the anaesthetist to determine the level of the spinal block. Starting at a dermatome cranial to the injection site, usually in the chest or thorax, the anaesthetist moves the cold stimulus in a caudal direction, as now shown, until the patient reports that the stimulus is no longer felt as cold. This denotes the sensory level of the spinal block or anesthetic. The required level will differ between procedures, with lower abdominal procedures requiring a higher block than procedures in the lower limb. The level of the motor block can also be tested by asking the patient to flex the hip or the knee. The level of the sensory and motor block should be documented before commencing surgery. A block must be given adequate time to work. If there was any doubt about efficacy, an alternative plan should be made for anesthesia.